Yes, I've made everybody post.
Perfect, perfect. Then I can share whatever I want.
Correct.
Yeah.
No?
Okay, we are live. Rohit, I would need your help, Ikbar, if you can just go on the page and see if we
Rohit,
are
please
there.
check कर लो एक बार.
Yeah, sure. Just reshare the link with me on the group now.
Sure.
Akash,
हाँ.
क्या लगता है? I mean, the background what Dr. Sandeep just was on, right? The white color background. Do you think करना चाहिए हमें भी? Yeah.
It's okay.
It's okay, I think, right?
So मेरे केस में तो भूषण already they are playing that background point
हाँ
of
हाँ,
care
yes, yes.
वाला.
हाँ, maybe
In
मैं
your
लगा
case,
दूंगा.
in your case already there is a good blank. मतलब it's looking quite blurry the way you want to keep it.
हाँ ठीक है ना, डन. मैं देखता हूँ, मतलब बिकॉज मेरे आने को बहुत टाइम है, सो I'll decide.
हाँ, as long as वो कट ना हो तेरा सर और वो सब उससे, because वो वर्चुअल में कभी
वो
कभी
भी
कट हो
अजीब सा
जाता है.
लगता है यार.
डॉक्टर संदीप का तो सही लग रहा है. It's
हम्म,
not getting distracted, but sometimes that background gets disturbed.
मुझे तो वो स्लाइड डेक ढूंढना है ना. इधर क्या? कॉल के साथ में यूज किया था ना इसको, POC एग्जांपल. सो आई एम शेयरिंग माय स्क्रीन. हाँ आकाश, कैन यू सी?
Yeah, I can see Bhushan.
दिस इज
Yes,
द वन, राइट?
correct.
So let me keep it everything here, right? I mean,
हाँ,
property.
तेरा हैंडी रख दे.
नहीं, what I'm trying to say here is maybe I'll just highlight this pro-BNP here. What do you say? Or कैसे?
हाँ, just talk about how handy the device is.
नहीं, वो नहीं
And
बोल रहा हूँ, वो नहीं
हाँ,
बोल रहा हूँ, because on this image वो तो मैं कर लेगा,
तो
but
यहाँ पे भूषण let D-dimer and top T be there, so they know it has other opportunities. But एक बॉक्स बना ले सिर्फ
हाँ वही
NT-proBNP, because that's our focus area. तो उस पे there can be a
done.
small box around it. Yeah.
Okay, चले.
Meanwhile, दृष्टि कैसा लग रहा है वहां पे? बराबर रोहित चेक किया?
Because both the places, the scheduled timing is 8 o'clock now. So
हाँ.
that's why the join now button is not activated now.
अच्छा.
So yeah, so that's why I am a little skeptical कि मैं छेड़छाड़ करूँ कि नहीं.
नहीं कोई don't mess with it as long as you are
Yeah.
confident. दोपहर को तो किया ही था
Yeah.
एक बार check.
Yeah,
हाँ,
Akash. In the
हमने-
afternoon we did it. It was working quite well. So I don't think so. It should be a problem.
Don't mess with it. The point is, the good thing is because sir has come on time, he will obviously join again on time. So we will start it sharp at 8 o'clock.
Yeah.
ठीक है. So we will also just go at least off the video for some time. 5 minutes पहले join कर.
Bhushan, am I audible?
Yes, we can hear you, Dr. Sandeep. Bhushan, you are on mute in case you're talking.
No, I think this
डॉक्टर
is
संदीप
not.
आवाज थोड़ा कम ही है तो.
No, I think this is. Earphone is not working either. That's what I'm saying. Okay.
अभी तो आवाज आ रही है doc at the moment.
I'll not use the earphone.
हाँ, this is better.
हाँ ये बेटर है, क्लियरर है.
हाँ.
हाँ.
Okay, so good. Thanks.
So, Drishti, meanwhile, can you make a WhatsApp group between the four of us, Akash, you, me, and Dr. Bhushan, so that in case in between, if there is some issue, it can be posted on the group itself.
Yeah, yeah. I've made Mr. Akash the admin. Maybe he can add Mr. Bhushan. I don't have his number.
Yeah, sure.
I'll do that.
So, Akash, we are going ahead with the immersive view for yourself and Dr. Sandeep, right? That's fine.
Yes,
after
for me
that,
and Dr. Sandeep, there will be this auditorium view, immersive
Correct.
view. उसके बाद, as soon as Dr. Kalra and Bhushan take over, normal रहेगा. At the end, when I come to close, we go back to that view.
Perfect. दृष्टि, तुमको अगर एक बार चेक करना है तो कर लो, because I saw that Dr. Sandeep was using some Roche वाला background. So if you want to check that, when you get him into the immersive view, तो it should not be any clash of backgrounds. वो एक बार चेक करना है.
हाँ, कर लेते हैं. I will first add Akash into it.
Yeah.
और कहीं पे भी टेक्निकली कुछ ऑफ लगे टीम, just go back to the basics, okay?
Okay.
Yeah.
Immersive निकाल देना.
Why is it so
दृष्टि, join now का
Oh, sorry. I am on this thing.
join now का button activate हो गया है, हाँ. So ideally it activates 10 minutes before the webinar. So now
Got
it
it.
has been activated for everyone. So whatever we are testing, let's quickly do it because somebody might join.
Yeah.
So it's live. That's what you want to say, Rohit?
Yeah, yes.
Oh.
Your placement is fine?
अब मेरा जो ऊपर का सर कट रहा है, so I need to keep this ऐसे, no?
This is fine, right?
Yeah,
Okay.
this should be okay. ये angle पे where we have that screen also, and I
Yeah.
can come this way. Dr. Sandeep का भी देख लो एक बार.
Okay, so once you are done, then I will remove you. ठीक है?
Once I am done, take me off. Then Dr. Sandeep should come in my place.
ठीक है?
Yeah. Sir, आपका angle सही है sir, आप you're on mute.
I think perfectly
मेरा-
fine. Yeah.
मेरा बीच
Perfect,
बीच
yes,
में
sir.
थोड़ा सर ऊपर हो जाएगा.
Just
Yeah,
one
Drishti, you
point.
have to
Sorry.
immediately minimize yourself, huh?
Yeah.
Just one point here, because the left side of the presentation whereby you would be introducing Dr. Kalra, Dr. Sandeep, अगदी तुमच्या डोक्याच्या वरती असेल. So his image
Okay.
will that way.
Got it.
Hmm.
Okay. So then once Dr. Sandeep is
Once,
done,
correct.
then I am leaving this immersive view.
Then leave
Okay.
the immersive view. We go to normal scientific view where Dr. Kalra comes in and starts his presentation.
Yeah, Dr. Kalra comes in. I switch on the spotlight on him so that
Correct.
he's only activated. Like for now, I have done the spotlight on you.
Correct.
Okay. So I remove spotlight. Right now, maybe I'll try with Mr. Bhushan. Then he's there. And then when the panel discussion is coming, I will just change the grid and make it, I'll put the spotlight on two people.
Perfect.
So guys, I think now we should stop discussing because it's live.
Yeah.
If we are done with the testing. So immersive view, okay, Akash, can we have you ready?
Sure.
Yeah. I'll drop off from here then.
Yeah.
Thank you so much. All the best to everyone.
Oh, okay.
Good evening, Dr. Team. Can you just give me a heads up? Shall we start?
Can we wait for 2 more minutes? Doctors are joining.
Sure.
Akash, can you, or Acha, Bhushan is there. Can you send me the audience link on WhatsApp?
Sure, sir. Yeah.
Mr. Akash, I think we can start by 8:05. Or if you want to start right now, we can start.
I think we can start now.
Sure.
Good evening, everyone, and a very warm welcome to one and all. It's the month where we celebrate the World Health Day, and we at Roche, we truly believe in our purpose of doing now what the patients need next. We are thrilled to host this very important webinar this evening, where we are launching and introducing to the medical fraternity a new claim that shall revolutionize the diagnosis and consequently the management of type 2 diabetes and associated cardiovascular risks in our country. A new study published in Lancet estimates that about 101 million people in India, which is about 11.4% of the country's population, is living with diabetes. And as per data, around 30% of diabetic patients will develop heart failure in their lifetime. In fact, T2DM patients are 8 times at higher risk of heart failure versus the non-diabetic population. This alarming data truly underscores the need for screening diabetes patients who could be at the risk of heart failure. At Roche, we truly believe and want to bring in technologically advanced solutions that can propel medical science and truly bridge the access gap between patient and diagnostic solution. Imagine how convenient it would be if each one of you experts is equipped with a simple, handy point-of-care diagnostic device in your setup that could help you identify the T2DM patients who could be at the risk of developing heart failure within just 10 to 12 minutes. How convenient it would be for you to quickly triage such patients and plan their treatment and lifestyle modifications based on their degree of CVD risk. This is exactly what we are proud to unveil today. A validated, lab concordant point of care test to help you screen type 2 diabetes patients who could be at the risk of heart failure. So without further ado, To take forward the proceedings, I would like to invite Dr. Sandeep Sivlikar, Head of Medical, Scientific and Regulatory Affairs at Roche Diagnostics India and neighboring markets. Over to you, Dr. Sandeep.
Yeah. Thank you, Akash. I think you really set the context right, and very good evening to all the experts joining from various parts of India. A warm welcome on behalf of Roche Diagnostics India. I think today's for joining for today's momentous occasion, that is launch of point of care NT-proBNP test for the screening diabetes patients who are at risk of developing CVD risk such as heart failure. So throughout our 125 years of history, Roche has grown into one of the world's largest biotech company as well as leading provider in vitro diagnostics and global supplier for transformative innovative solutions across major disease area. So we provide broad range of innovative diagnostic tests and system which really play a pivotal role in the groundbreaking area of integrated healthcare solutions and cover early detections, targeted screening, evaluations, and disease monitoring. So in fact, throughout the entire clinical continuum of the patient. So nevertheless, as Akash just highlighted, point of care testing or its technology is evolved over the years to address the unmet medical need. Definitely from a patient's side as well as from a treating physician side, with only one objective: how best we can enhance patient care as well as better clinical outcome. So we at Roche, we are dedicated to advancing healthcare through innovations as well. So today's point of discussion, that is extended claim on our NT-proBNP test, now available on our point of care system, that actually underscores our mission to empower clinicians with a cutting edge tool for early diagnosis and personalized patient care. So NT-proBNP test for diabetes at point of care marks, I think, significant milestone in the journey towards proactive and personalized healthcare for diabetes patients who actually are at risk of CVD, cardiovascular disease, as well as including heart failure. So this breakthrough innovations definitely is designed to bring that testing closer to the clinic and revolutionize the patient care that we use, where we are facing some challenges on identifying the patients who are at risk. I think it's more relevant and useful in Indian context, as Akash just shared about like 101 million people living with diabetes, and I think we all know was the morbidity and mortality associated CVD risk related morbidity and mortality in type 2 diabetes nation are almost 46% actually at risk of developing cardiovascular disease, that is also including heart failure. So actually it highlights the importance of how early we can identify the patients who are at risk is equally important. I think that really help us how we can really leverage this information for better patient care going forward. So with this, I think the innovations that today we're discussing, the Roche Diagnostics India's NT-proBNP test on the point of care device, that is Cobas H232 system, definitely will help facilitates early detection, that is screening, and interventions actually help us enabling clinicians to identify high-risk type 2 diabetes patients and initiate timely treatment discussions. So I think thank you for joining for today's webinar. Without further ado, I would like to invite our keynote speaker for today's webinar, Dr. Sanjay Kalra, who is renowned endocrinologist, chief endocrinologist and proprietor at Bharti Hospital, Karnar. Now, if you see, he's a global speaker. I think more than 1,000 lectures on various aspects of endocrinology and various parts of the globe, Europe, America, Africa, Asia, Australia, to share what new things, what new innovations going on in the space of diabetes and endocrinologists. So he is currently an executive board member of International Society of Endocrinology, chairman working group, education working group at ISE. He is a past president, Endocrinology Society of India, Also past president at SAFES, that is South Asian Federation of Endocrinology Societies. He's also editor-in-chief for ESI textbook of Endocrinology 3rd edition, International Society of Endocrinology education editor. So he has major interest in driving various clinical studies in India, part of global studies that conducted where India was part of those landmark studies, where India was part of these global studies. He was principal investigator in more than 50 global phase 1, 2, 3, 4 clinical studies, right from like first in man studies to the pivotal phase 3 studies and post-marketing surveillance studies as well. So he was his principal investigator Haryana for Indian Council of Medical Research, that is IDA, India B AB study. So without further ado, he has just to Shri, he has more than 840 publications in index journals that published on PubMed. So over to you, sir, to take the proceedings further.
Thank you, Dr. Sandeep, for that warm introduction, and thanks to Akash as well for setting the stage for today's talk, for today's webinar. And a warm welcome to everyone who is logged in with us. 7th of April is World Health Day, and we all know the theme for this year. The theme is My Health, My Right. And this is a very person-centric, a very citizen-centric kind of an approach. My health, my right means that each and every individual, each and every fellow citizen of ours has the right to good health. Now, what does good health mean? Good health can mean different things to different people. We know the WHO definition. It's not just about physical well-being. It's also about social, mental, emotional well-being. Not only that, there is a concept of sustainable health. If I have good health today, I am asymptomatic. That doesn't necessarily mean that I am truly healthy. True health means that I should be able to sustain this health over an indefinite period of time. So if today I can do something to prevent ill health tomorrow, that is also part of good health. And when again we look at the WHO theme, my health, my right, it means that I have the right to preventive interventions. These preventive interventions, apart from curative ones, these preventive interventions can be diagnostics, they can be drugs, they can be devices. And as a citizen of my country, I have a right to all of them. So this too is part of the definition of health. There is another aspect of health. This is called the index of intrusion. Now, suppose a situation exists, an ecosystem exists where I can be healthy. But to access health, to access the means to health, I have to travel maybe 100 miles. I have to come back twice to the same healthcare system just to get my report. It takes me 2 trips to the hospital to get one drug initiated. This is known as a high index of intrusion because these activities, going to the hospital again and again, traveling long periods of time, waiting for lab reports, these intrude into my preferred lifestyle. During that time, I could have gone to work. I could have focused on my profession. I could have relaxed with friends and family members. I could have focused on my personal life. Having to move away from professional and personal life actually impacts my health negatively. So therefore, the definition of health also will include access to, availability of, affordability of, appropriateness of health. Yet another aspect of health is the timely provision of healthcare services, whether curative or preventive. So a stitch in time saves 9, they say. And if you are able to get health in a timely manner, that will help you prevent ill health later on. But if health comes too late or health services come too late, there's no advantage. It's like this concept of Ganga Jal, the holy Ganga Jal, Ganges water that we have in our country, in our philosophy. If you take a bath in the Ganges, if you take a dip in the Ganga water in a timely fashion, you are absolved of all sins. But supposing you don't do that, and someone is on his or her deathbed, and then the family members pour Ganga Jal into that person's water, it means they have given up. It means it's too late. The point of discussing all this is that the WHO theme, my health, my right, is really appropriate. But at the same time, my health, my right should be available. It should be accessible in a timely manner. So let's focus upon this aspect today of good health, and let's see how we can improve our health by using a new device, a point of care device with NT-proBNP. It's always great connecting with you. Now, there are times when you do get in trouble when you're on a webinar. For example, when your slides don't download, even if you had checked them earlier. And we all have this experience in medicine. You run a test. Let's say you do a sodium potassium. The sample gets hemolyzed. When the patient comes back expecting the potassium report, you have to tell the patient, sir, apologies, madam, apologies, we'll have to call you again for another test. So these kind of things do happen in practice. But we'll move on and let's talk about what we can do in practice now. And one of the things that we can do is to help our patients with type 2 diabetes live a healthier life. If we want our patients with type 2 diabetes to live a healthier life, we have to prevent complications. That is the only way they can remain healthy. And remember our definition of health, it's not just about good health today or being asymptomatic today, it's about being asymptomatic tomorrow as well. In spite of saying all this, doing all this, many of our patients do present with complications. And quite a few of them present with cardiovascular complications. When we think cardiovascular, we often tend to think automatically of myocardial infarction, angina, and stroke. But the reality is that heart failure is much more common than stable angina or myocardial infarction or stroke separately. Heart failure is common because, first of all, it has an ischemic angle to it, an ischemic etiology, but there is also a non-ischemic etiology of heart failure. And because of these dual etiologies, you find that heart failure affects more than 1/5 of all people with diabetes. The relative risk of developing heart failure in diabetes is 1.85 as compared to those in people without diabetes. If the risk of heart failure is twofold in men, it is fourfold in women living with diabetes. And heart failure is associated with the highest risk ratio of death and decrease in lifespan out of all the CV complications, which means that we can prevent death due to a myocardial infarction or stroke in a much better way than we are currently able to prevent death due to heart failure. We can change this if we prevent heart failure before it begins. Once heart failure occurs, that is a death knell, that is a sign of impending death. But if we prevent heart failure from becoming symptomatic, perhaps we can take action. We can benefit our patients. And this aspect becomes more and more important as our people age, as our population ages. Because as age increases, type 2 diabetes increases, and so does the risk of heart failure. The current staging of heart failure says that virtually every patient coming into the diabetes clinic, or many people coming into the medicine clinic with diabetes, hypertension, heart disease, familial hypercholesterolemia, or with the intake of cardiotoxic drugs, have stage A heart failure. This leads on to stage B heart failure, which is asymptomatic, but is associated with surrogate markers. So there are no symptoms, there are no signs, but there are surrogate markers of heart failure, heart insufficiency. These can be seen on imaging, like left ventricular hypertrophy or low ejection fraction, but also they can be seen through biomarkers, like an abnormal NT-proBNP or a raised highly sensitive cardiotroponin. Once you move from this asymptomatic phase, the preclinical phase, to stage C, it actually becomes too late. Stage C heart failure is someone who has current symptoms or who has had symptoms in the past. And as this worsens, finally people reach the stage of refractory heart failure, which is difficult to treat. If we wish to prevent people from becoming symptomatic, from dying prematurely, we need to catch them at the stage B level so that they don't reach stage C. And this is really important in people with type 2 diabetes because multiple factors, like we said, ischemic and non-ischemic, both lead to heart failure. You can just imagine that diabetes is a state of maladaptive anabolism. There is anabolism because there are high insulin levels. Insulin is an anabolic hormone. But the insulin doesn't work. There's insulin resistance. So it's not anabolism in the true sense. It is a maladaptive or a failing anabolism. A similar thing happens in the heart in people with diabetes. There is anabolism at the level of the heart because you see that the size of the cells increases. So that is anabolism. There is increase in the biomarkers and the neurohormonal levels in the various cells, whether it is the kidney or the heart, like the renin-angiotensin and aldosterone system. There is an increase in formation of advanced glycation end products. So that is formation. That is also anabolism. But all this anabolism is maladaptive. It is a sign of failure because these cardiomyocytes which hypertrophy, sooner or later they are going to get tired. They will get fibrosed and they will not be able to work properly. And we will end up with reduced ejection fraction. Apart from all this maladaptive anabolism which is going on in the heart, there is the concept of ischemia, which keeps on worsening. Ischemia will keep on worsening with age, and the cells of the heart will gradually get squeezed out of all the oxygen that they need. And all these make the heart fail. Why is this important for us? As people who look after persons with diabetes, we have to take care of all our patients' needs. When we read the guidelines, we can be excused actually if we think that the guidelines tell us to be only cardiocentric. But it's actually not like that. It's not like that at all. Let's look at Maslow. Now, Maslow was a behavioral scientist. He was a behavioral scientist who created Maslow's hierarchy of needs. What he said was that each and every individual on earth first needs to fulfill his or her basic needs. Roti, kapda, makan, food, clothing, and shelter. Along with this, there are safety needs, security and safety. Only after these are fulfilled do you move on to psychological needs like belonging, love, affection. Once you get that from your family and friends, then you want esteem. Then maybe somebody would want to become president of the Rotary Club or president of the Lions Club or become leader of the local temple group or church group. These are needs related to esteem. And once you cross this, then you reach the stage of self-actualization, would be something like Lord Buddha. A similar thing plays out in our diabetes clinic as well. Some patients come to us with basic needs. They will come and say, sir, madam, I go too often to the bathroom at night. I'm not able to sleep. Give me a medicine so that I can reduce the need to go to the bathroom. I have a foot ulcer which is not healing. I've lost weight. These are my needs. Please fulfill those. I have breathlessness. I have dyspnea on exertion, easy fatigability. These are my needs. The good doctor focuses on symptomatic relief first. Once that is done, then you move to other safety needs, and in diabetes, it's effective glucose control. So some patients will say, sir, I don't have any symptoms, but please take care of my glucose. My fasting is 127. My postprandial is 201. Please bring these down for me. It's only after you have done this or while you're doing it, you can do it sequentially, you can do it simultaneously, that you begin focusing on cardiovascular and visceroproductive benefits. And then we'll tell the patient, you see, madam, now you're doing fine. You are healthy today. Your glucose levels are fine. But please let me give you a medicine which will help improve your long-term outcomes, micro as well as macrovascular, heart-related as well. And to do this, I need to do some tests which will tell me at what risk you are. If you're at high risk of heart failure, then we'll give you a medicine to prevent heart failure. So this is the way we speak with our patients. Now, depending upon where we are working in India, the proportion of patients at different levels of Maslow's hierarchy will vary. If you're working in a small town, in a rural area, you will have more patients coming in with symptoms. If you're working in a very posh area, a very educated area, people will come in early and they will speak more about cardiovascular and visceroprotective benefits, also about psychosocial issues. Where I work, it is a 50-50 mix. So we have patients coming in with severe diabetes, with symptoms, with sickness. And then we also have people who are stable, who come and say, can I do better? My glucose is already under control. Can you predict my future? Can you help me reduce my cardiac risk? Now, this is supposedly a very simple question. Can you reduce my cardiac risk? If you wish to answer yes to this, first of all, you have to tell how you are going to measure the cardiac risk. So we do know the various clinical features that are associated with heart failure. High blood pressure, high body mass, atrial fibrillation, obstructive sleep apnea, increasing age, poor glucose control, long-standing diabetes, associated microvascular disease, and use of aggressive drugs, some drugs. But all this put together is not a very objective way of finding the risk of heart failure. So they do have objective risk prediction tools. SCORE diabetes is something that is in the news these days because it's a new one, SCORE CVD. But the thing is, SCORE CVD is valid only for European populations, not for ours. PCP, preventing heart failure. PCP, heart failure, preventing heart failure in clinical practice. This is a good tool and it has a lots of variables, but it doesn't use diastolic blood pressure. And many things like renal impairment are missing in this. Watch DM is another good tool, but with Watch DM, they don't even talk about the treatment for hypertension, the treatment for diabetes, which actually impacts our risk to a major extent. QRisk 3 is something that is approved for use in the United Kingdom. In QRisk 3, the advantage is you can enter your ethnicity. So you can put in Indian ethnicity. You can also put in Bangladeshi or Pakistani or other Asian ethnicity. And this will give you a fair risk of cardiovascular disease, but not of heart failure. So all these are limited. None of these tools will actually tell us about heart failure. And when you assess them, you find that they are suboptimal in predicting long-term risk. But if we wish to predict the future, how do we do that? Now, you can go to the astrologer, for example. You can go to the palmist, the palmistry specialist. So I might wish to ask, a friend or an expert, could you please read my hand and tell me what my future is? But that won't be very accurate. We do, however, have something known as medical astrology. And there are experts in medical astrology who will predict when a particular baby should be born, when a particular delivery should be done. So these things do exist in our society. But if you want evidence-based medical astrology, that you get from biomarkers. And one of the biomarkers that has been proven to be effective in finding the risk of heart failure is NT-proBNP. Now, this is a cardiac hormone. It is a peptide. BNP is B-natriuretic peptide. It is a peptide. It causes natriuresis. If there is excessive sodium load, if there is excessive water load, the body will respond with natriuresis. You have A, B, C, NP. So there is ANP, BNP, CNP. BNP is secreted from the ventricles of the heart. BNP is a long peptide, but there is also something known as proBNP, which is the precursor. ProBNP is an even longer peptide. It's not very stable. But if you take the N terminal of proBNP, that is a very stable molecule. And you can assess NT-proBNP in people with and without diabetes, with no overt heart disease, without symptoms, without signs. You can assess them. And independently of blood pressure, sex, age, pulse, and BMI, you can predict the onset of heart failure. So if you look at the slide in front of you, if there is a clinical heart failure event that is about to occur, you can predict it beforehand if you do an echo, if you look at the structural changes. But if you do the biomarker test, NT-proBNP, you can predict it even earlier. So that is the advantage of doing NT-proBNP. It is a mirror into the future and it helps predict adverse events. In fact, studies have found that if you look at the temporal profile of NT-proBNP, you find that it begins to rise in people with type 2 diabetes about 180 days prior to hospitalization for heart failure. So the hospitalization for heart failure will occur today. But had we done the NT-proBNP 6 months earlier, we would have been able to find out that yes, the risk of heart failure is going up. So therefore, we need to take action. And this is true for people with a history of heart failure in the past, also those without heart failure in the past. So it is useful. NT-proBNP is useful for primary prevention and also for secondary prevention, for both. For tertiary prevention as well, because it prevents complications of heart failure. So that means that if you do an NT-proBNP every 6 months or so, you will be able to predict CV outcomes, hospitalization for heart failure. But then the question will come, that is what HbA1c is for. Yes, that is true. HbA1c does help predict CV outcomes. The higher the HbA1c, the worse the CV outcomes will be, the more the risk of hospitalization, the more the risk of cardiac hospitalization, and unfortunately, the more the risk of mortality. But if we were to compare NT-proBNP with HbA1c, we find that over a mean follow-up of 40 months, it is NT-proBNP which turns out superior. So NT-proBNP is statistically significantly better than HbA1c in terms of predicting all-cause mortality, cardiac hospitalization, CV hospitalization. Also, the absolute change of NT-proBNP is more effective in predicting cardiac hospitalization, CV hospitalization, and all-cause hospitalization as compared to the absolute change of HbA1c. So every few percentage of NT-proBNP reduction actually talks about reduction in mortality. So we spoke of this concept of medical astrology. Another way of putting forward this is cardiac HbA1c. So if HbA1c is a glycemic tool, NT-proBNP is a cardioglycemic tool or a cardiac tool. Another aspect that is used in practice is albuminuria or microalbuminuria. And we know that microalbuminuria is the bridge between macro and microvascular disease. But when you look at NT-proBNP, you find that that is superior to albuminuria as well for predicting CV events in people with diabetes. And you find that this is visible within just a few months. In this study, where the mean follow-up was continued for about 33 months, they found that within a few months, all these graphs began to diverge. And people with an NT-proBNP more than 125 picogram per ml actually had a greater risk of CV events than those with albuminuria, irrespective of the albuminuria level. So if we wish to use one biomarker for predicting the future in people with type 2 diabetes, out of NT-proBNP, HbA1c and albuminuria, our vote will be for NT-proBNP. But then the question will come, sir, you have been speaking about problem statements. You are speaking of changing the future. We are a country that wants to grow. We want to become better, healthier. And we are just talking about predicting the future, and you are acting like, someone who is like doomsday. Like you are always talking about all the negative things. But that's not true. NT-proBNP actually helps us change the future. And in the Pontiac 1 study, people with type 2 diabetes and elevated NT-proBNP were randomized to two groups. One was the control group, which got routine care. The other one was intensified group, which also got treatment from a cardiac clinic. And RAS blockade and beta blockade, that was the standard of care at that time. Of course, now we have better drugs. They were given in an optimized manner. NT-proBNP was measured using a POC, a point of care device, a very small, simple and handy device. The patients who were included were those who were asymptomatic adults with type 2 diabetes. Not only were they asymptomatic and they had no signs, they also had a normal ECG, normal echo. The only abnormality was a surrogate marker, NT-proBNP more than 125 picogram per ml. Their NT-proBNP wasn't even 250. It was not diagnostic of heart failure. It is just NT-proBNP more than 125 that they had. And when we compared the two groups, we found that those who had got intensified therapy had a lesser risk of hospitalization or death due to cardiac events. This was statistically significant, and the hazard ratio was just 0.35 for hospitalization or death due to cardiac endpoints. This means that just picking up the NT-proBNP more than 126 or more with a point of care device helped us plan therapy. So not only like in medical astrology or in Indian astrology, you are able to predict the future. You must have seen in our culture, anyone who talks to you about the future will also have an upay or a solution for that. So that solution might be wearing black clothes every Saturday. It might be going and donating rice every Tuesday or every Friday. But here it is just about going to the clinic, getting your RAS blockade and beta blockade up titrated, and following up carefully. With this, you can reduce the risk of death, reduce the risk of disease. Now, all these have been accepted and are used in modern guidelines. When we look at the ACC guidelines, that is from USA, we find that patients who are at risk of developing heart failure should receive team-based care, guideline-directed medical therapy, and the screening should be based on natriuretic peptides, that is NT-proBNP. This will help prevent the development of left ventricular dysfunction and also new onset heart failure. From Europe, we have the 2019 ESC guidelines on prediabetes, diabetes, and CV disease. These were developed in collaboration with the Cardiology Society and the Diabetes Society of Europe. And what this is that NT-proBNP has been found to be valuable in identifying that subset of patients with type 2 diabetes who will benefit from intensified control. So the prognostic value of NT-proBNP is well known here. We have good guidelines from our colleagues in Japan as well, who mentioned the same thing. Recently, the American Diabetes Association came out with a stepwise approach for evaluation and diagnosis of heart failure. So at stage A, that is, everyone with diabetes is at high risk. They say you check biomarkers. If they are normal, you check after a year. If they are abnormal, then you go ahead with treatment. Do the imaging, differentiate between heart failure with preserved or restricted ejection fraction. And we actually acknowledge the question from Dr. Syed, who asks about ejection fraction and heart failure. We also acknowledge questions from Dr. Manju and also from Dr. Shivamalla Reddy Mekla. We'll all take them shortly. And of course, treatment has to be done as per standard of care. But what the ADA consensus says is that you should check these biomarkers at least once a year in every patient with type 2 diabetes, even if they are asymptomatic. Of course, if the patient is symptomatic, you will check more often. Biomarker screening helps provide timely aid to patients. So, when we speak of first aid in medicine, first aid means being the first responder. But how do you respond properly? You can't respond if you don't know details about your patient. And biomarker screening can be considered like a biochemical first aid. So you do the biochemistry. That itself is part of first aid because that will help you decide what you can do later. And this biomedical first aid or this investigative first aid is something that has been highlighted in the diabetes technology study consensus as well. Here we had experts from across the world, including India. And what they suggest is that we should have NT-proBNP testing in people with type 2 diabetes of all ages, in people with type 1 diabetes from age 30 onwards. Type 2 diabetes should be screened from the time of diagnosis onwards. Type 1 diabetes, you can begin screening 5 years after diagnosis. Annual screening should be done. NT-proBNP or BNP can be tested, and you can check at any time of the day without regards to the clock or without regards to meal time. The moment you get an abnormal biomarker test, it means patient has shifted from stage A to stage B, and then you may need an echo. Now, some of us may ask, echo is more effective, echo is more accurate. But actually, when you look at the data, you find that NT-proBNP is able to pick up people even with a normal echo. It's able to pick up people at high risk of heart failure, even if they have a normal echo. So actually, NT-proBNP should precede the echocardiogram. This is like good clinical sense. In endocrinology, for example, let us say you are doing a workup for pituitary or for adrenal. This is the order. The hierarchy is first take a history. then do an examination. Then you do the lab testing. So I will do a serum cortisol or a serum growth hormone. I will do a suppression test for growth hormone or for cortisol. I will then identify which part of the body is probably involved. Is it the pituitary or is it the adrenal? Only then will I do imaging. So that is the order we follow in endocrinology routinely. First clinical, then screening with lab tests, and then imaging. If we do this, the errors are less, and you are able to manage things like incidentalomas much more easily. Similarly, in heart failure, the first step would be to take a clinical history, ask questions. After that, you do maybe an ECG and an NT-proBNP, and then you decide about echo and further testing. So that is the order to follow. And this is part of good clinical sense. If the NT-proBNP is less than 125, that is what the 2023 guidelines say, or less than 365 picogram per ml in atrial fibrillation, the diagnosis of heart failure will be unlikely. So find another cause for maybe easy fatigability, for chest pain, for discomfort. If, however, NT-proBNP is high, then even if the patient is asymptomatic, you have to work up more carefully. Then you may wish to do an echo, do other tests, define the heart failure phenotype. So like the question was asked, what is the difference between restricted ejection fraction and preserved ejection fraction? Preserved ejection fraction means more than 50%. Restricted means less than 40. In between, 41 to 49 is moderately restricted ejection fraction. We also have some patients with heart failure who have increased ejection fraction. Examples would be severe anemia, A for anemia, A for arteriovenous fistula, and Graves' disease. These are some examples, severe anemia, AV fistula, Graves' disease, which are associated with increased ejection fraction, but with heart failure as well. So now we are coming around to the fact that, yes, we do need to take care of our fellow citizens, our patients with type 2 diabetes. We need to give them good health today and also tomorrow. Even if they are asymptomatic today, it doesn't mean that our responsibility finishes. In that Maslow's hierarchy, in that Maslow's pyramid that you saw, even if we have taken care of glucose control and symptoms, we need to move up and we need to take care of cardiac health. Not only today, but tomorrow and day after tomorrow as well, for as long as they live. This is known as metabolic karma or cardio karma. What does cardio karma mean? Now, karam, the Hindi or Sanskrit word karam in our philosophy can mean past tense, present tense, and future tense. Whatever we did in the past was our karam. Because of that, maybe I was a chain smoker. I didn't exercise. I didn't go to the doctor. I have got my karam today. My karam is that now I'm sitting in the diabetes clinic. No point in crying over spilt milk. But today, whatever cardio karam I do. So if I take the right decisions based upon the right investigations and I take care of my heart, I will be able to influence my karam tomorrow. That is my outcomes tomorrow. So karam means determinants. Karam means present tense experience, and also it means outcomes. This cardio karma is quite easy to explain to our patients because you tell them, see, whatever has happened in the past, let us just find out with a single number called NT-proBNP. It's not difficult to remember the numbers also. You remember the diagnosis of diabetes? Post-load fasting above 126. That is diabetes. So similarly, 126 and above or 125 and above means you are at high risk of heart failure. The same respect that we will give to a glucose value of 126, a fasting glucose of 126, the same respect, neither more nor less, will we give to an NT-proBNP of 126 or more. Because that means the patient is at high risk of heart failure. And if both these numbers converge in a person with diabetes, uncontrolled diabetes and high NT-proBNP, then the risk is compounded. It is not just additive risk, it is supra-additive risk. You can explain the concept of compound interest to your patient. Even when we speak about karam, your patients will say, but sir, the Bhagavad Gita tells me to be inactive. It tells me not to do anything at all. if my NT-proBNP is high, that is my cardiokarma, I should suffer the consequences. The answer is no, not at all. There are three aspects if you come to philosophy. So one is action, which is karam. The other one is inaction or actionlessness. And the third part, which is mentioned in our philosophy, is vikaram. The Hindi word is vikaram, which means meritorious action. So karam is action, vikaram is vikaram is meritorious action. And if you are able to take action for your patient in a vikarmic manner, by intervening, by getting the NT-proBNP done, by introducing the proper therapy, cardioprotective therapy, you will get better outcomes. And the karam that your patients gain, the cardiac health that they gain, should hopefully transfer back to us sometime in this life or in future. So that is how you interpret the NT-proBNP values. To make it easy for myself in the OPD, what I've done is less than 100, remain calm, 100 to 125, just like pre-diabetes, we will become vigilant. And above 126, that is just like diabetes, we will become super vigilant and we'll go into action mode. We'll go into karam and vikaram mode. If the NT-proBNP is normal, we'll repeat again after 12 months, maybe 6 months. But if the NT-proBNP is high, we can repeat after 6 to 12 weeks as well. NT-proBNP is like a VAT, not like a value-added tax. Patients will say, sir, you added a few thousand rupees to my bill. It's not the tax that we are adding. It is actually value-added therapy. We are adding value to your therapy because we will be able to choose the right medication for you, both glucose lowering as well as cardioprotective. And NT-proBNP will help us identify the patients who are at high risk of heart disease. It will also help us identify what kind of medication we will give. It will also help us monitor them in a more careful manner. And it will help us actually improve the health not only of one particular individual, but of our entire country. If we were to choose one cardio-specific biomarker, it would be NT-proBNP because we see data. It is more accurate than HbA1c, than albuminuria, and also than the clinical risk models. And this is approved by the latest comprehensive coverage or the comprehensive guidelines that we get from across the world. With this, we'll move on to lots of questions, but we have our team, Dr. Bhushan, Akash with us. Dr. Bhushan, your comments, is it important to be able to predict the future? Does everyone who enters diabetes clinic or a healthcare system, if you've ever gone, have you ever worried about what's going to happen to me and whether I'm in safe hands or not?
Actually, that was something I was planning to ask you, sir, on behalf of entire audience, because these are the questions what we are, just to let the entire group here, we are flooded with the questions. We are already having more than 175 questions from the audience. But just to be, just to answer your question, sir, personally speaking, definitely, if I get diagnosed as a pre-diabetic or I have a family history, definitely I'll go for this one. But let's say that, I do not put my own personal experience in front of entire audience. If I just say what other clinicians who are using NT-proBNP in their regular practice, just like you, Dr. Amey Joshi, Dr. Sahana Shetty, and everybody else from entire India, in fact, outside India as well, including president of ADA, that Professor Buzoi, they are essentially screening each and every type 2 diabetes mellitus for the risk of cardiovascular diseases. And that is, I personally believe, should happen, because as you actually pointed out multiple times in your presentation, that, type 2 diabetes doesn't come as a single disease. It brings along a lot many comorbidities along with it. Cardiovascular being the most prominent one, we should be very wary about this particular thing. Great, sir. Thank you so very much for this entire talk. It, just like every time, it's a great pleasure to listen to you because the way you put the analogies in place, and I'm sure the audience would really like it. With your due permission, sir, because we have been talking about the point of care devices, how it can be more practical for multiple clinicians who are practicing diabetes in their regular setup, right? If with your due permission, may I share my screen just to showcase the people that how does this device actually look like in the real world, right?
Certainly.
I hope my screen is visible.
Perfect.
Yes.
So I think this is what you are emphasizing, sir. I mean, the point of care, near patient testing. So by definition, it should be portable. We were talking about Cobas H232 system. And as Dr. Sandeep mentioned in his initial talk, this is basically the only approved device and the test which can basically screen the T2DM patients for upcoming heart failure risk. Now, with NT-proBNP, which is sort of highlighted in this red box, we can also do other tests like D-dimer and troponin T as well. And I think, as Akash mentioned in his initial context setting, we get the results within like 9 to 12 minutes. So this is, I wanted to showcase to the audience, which is by the way, more than 1000 right now, that this is how the device looks like in the actual setting, quite portable. And with this, what I can do, perhaps I can move on to the next part of our agenda. I had drafted few questions to you. I mean, but most of the questions you have already answered in your presentation. But I think so, because I'm referring to one of your slides whereby you presented the Maslow's pyramid, whereby you were putting the analogy out there. We know the hard truth or the real world scenario in India, our T2DM management is focused on the glycemic control. While you mentioned that it must be also thinking about the cardiovascular protection, how do you see, I mean, NT-proBNP's clinical utility fitting into this existing way of conducting T2DM management? I mean, your thoughts, sir?
I see it helping the quality of our care. Now, NT-proBNP is also already accepted as a means of triage in the acute care system. So supposing at night, a patient comes in with chest pain or with dyspnea or with easy fatigability to the medicine emergency. The nurse, the physician assistant, the physician can do an NT-proBNP and decide whether to triage to a cardiologist or to triage to the general physician or respiratory physician. So there it is accepted. In chronic care, what happens is we have so many patients coming to the OPD. We need a system of doing trials to see who is at higher risk and who is at lower risk of complications. Everybody with diabetes is not at the same risk. So if I can use NT-proBNP in my OPD, and I will use it along with HbA1c, not without, along with microalbuminuria, that will tell me which patients to spend more energy on, whether it is in terms of motivating them to take insulin or other oral drugs, and which patients I should refer for shared decision making, for shared responsibility to a cardiologist. So I think it will help the quality of care that I give my patients. Along with that, it is an ergonomic tool. Ergonomy means increasing efficiency. It will increase the efficiency of my clinic as an endocrinologist, because I will know whom to spend more time on and whom to spend less time on. It will finally help the patient as well. And in today's world, where sometimes you do worry about responsibility, it is always a good idea to share responsibility. So if you can document that the person has got a high or a low NT-proBNP, that tells you the level of responsibility you have, and it tells you how many pairs of shoulders you need to share it with. So I think in the even today, and as we move forward, the utility of this biomarker is going to increase.
Great, sir. I think I can correlate some of your sentences, sir, here. I mean, I can truly correlate that you always tell us that perhaps NT-proBNP is the next HbA1c. So in the initial few days, people were relying on the glucose, blood glucose level measurement, and the reliability of HbA1c or the overall need of A1c was put under the question. Do we really need it? But then the time passed on, and then people understood the need of the average value. But perhaps, as you rightly put into your presentation, this is the cardio A1C, essentially, if we will talk in that particular language. But I think this is something our audience should also look at it from that particular perspective. And in fact, you also talked about putting its analogy, because whenever we spoke to our clinicians, right, I mean, they were constantly worried about there are too many cutoff values to be remembered. But I think just to highlight one of your point, I think for audience, you specifically put the analogy that the fasting blood sugar level, that 126, this is something you can essentially correlate with the NT-proBNP level, and that would essentially make life of the clinician easier that way. Just one thing, because if I talk about point of care system, people are always worried about, are the point of care devices, the values which we receive from them are concordant with the central, the big machine value whereby we send our blood samples to. What's your take on that, sir? I mean, are they reliable? I mean,
Yeah,
how
they're
do you
very
choose them?
reliable. Yeah, there may have been a time, maybe 20 years ago, when point of
Mm,
care was not considered standard of care, but
mm,
today it is standard of care.
correct.
And the validity, the coefficient of variation, all these are very well taken care of.
Mm,
In
correct.
fact, when you analyze any analyte,
Mhm,
let's say you're doing a biochemistry test, there are pre-analytic, analytic, and post-analytic errors which are possible.
mm,
With point of care, actually, you are minimizing these. The
mm,
method is so simple that there would be hardly any scope for pre-analytic, analytic, or post-analytic errors.
mm,
While if you're sending to a laboratory, even though they do their best, the
mm,
chances of errors increase actually,
mm.
whether it might be mislabeling, it might be mixing up of samples, hemolysis of samples, getting the report late. I mean, a million things. So
Yes.
here it is real time. The
Yes.
other advantage, Dr. Bhushan, is that everyone who is listening to us today, all of us, we have so many patients. Now, in a diabetes clinic, actually, you get confused.
Mm,
Everybody has got diabetes. Everybody is roughly the same age group.
mm,
Either they are men or women. They have the same complaints, concerns, challenges. So you might mix up. Let us say I get my report tomorrow. And supposing the report is of Usha Rani ji.
mm,
But I saw 5 Usha Rani jis today in the OPD. Or
mm,
5 Mr. Rakeshes, which
mm,
actually happens every day. Or
mm.
where I work, it is 20 Mr. Singhs
Yes.
and 20 missed calls. So
Yes.
by tomorrow, I might mix up 2 names.
Mm.
So many times I try, you're from Canada, you're from Australia, your daughter is there. I try to,
Totally.
picturize them in my mind.
Yes.
But then everybody's aunt or niece is in Australia or Canada these days, in Haryana and Punjab.
Yes.
So when you get the point of care result immediately,
Mhm.
that error is also taken care of.
Yes. True.
The
Great.
error of suboptimal memory, that is also taken care of. So I would highly commend point of care devices actually. It has made
Actually,
my life very easy, Dr. Bhushan, in the OPD. I
yes.
cannot tell you how
Actually,
easy life has become for us now.
yes, exactly. And I could see from your comments, sir, I mean, technically speaking, it has become a great tool for patient education as well as motivation, as you were pointing out. So let's say that if the value is below 100, everything is great. I mean, the green flag. Somewhere between 100 to 125, then you have to be sort of aware, just like what we do for pre-diabetes people. And then above 125, 126 is like a red flag. You have to take extra care for those particular patients. That is something I think our audience, which is primarily endocrinologists or diabetologists, that I think they should be correlating it with their daily practice out there. I think, and that is what we wanted to bring to the notice of our audience, that these are the practical gems which are actually told by Dr. Kalra for the entire audience, that this is how it could be beneficial into the management of T2D patient. So, actually, one more important point, what we are observing, especially in the Maharashtra part of India, right? I mean, the role of paramedics here, I think they play a very important role. I just wanted to hear, I mean, because you have a private practice in city of Karnal in Haryana, how do you think about it, the role of paramedics and, point of care devices?
I cannot work without my support staff.
Yes.
And I would be the first person to say very humbly that there again may have been a time when the doctor considered himself sacrosanct or God's messenger on earth. Now it is teamwork which is required. Even when you read the Upanishads, Dr. Bhushan,
Mm,
it is the concept of teamwork is so clearly mentioned. let us work together, let us work for peace.
True.
Repeatedly, in all the Upanishads, they talk about teamwork. So without teamwork, I can't work. Now, if I need teamwork, it is to my benefit that my team should be empowered, my team should be educated. If I count the number of things which I do in a day, the types of things, that is less than what my educators are doing. They have a wider spectrum of things to carry out. So if I'm able to empower them by giving them easy, simple tools, one of them would be point of care devices. I actually end up empowering myself and the patient as well. So point of care is something that all our paramedical staff can begin doing. In my setup, it is the lab technicians who do it. And it takes less time actually. So things are much faster. Our paramedics are also trained to explain to the patient why they are doing an HbA1c, why they are doing an NT-proBNP, why they have to do a serum creatinine or sodium potassium. So the simple thing, the paramedic may say, "Madam, this is for your safety. This is just to check that we are giving you the right dose of a particular drug. And this is to tell us whether we need to send you for an echo or an X-ray or maybe an angiogram. So we'll get this done and then we'll decide." So these basic simple things they are able to explain to the patient, and patient is grateful for that.
I think this is great insights, especially for the private practitioner out there, especially in the tier 1 and tier 2 cities. This is a great insight, learning from the master who in the field just like you. But perhaps it's now the time to move on to the next part of the agenda, which is like audience questions. And just to highlight here, I mean, we are witnessing unprecedented level of questions here, sir. Just to give you the context, we are already at the level of 200 plus questions. Maybe it's the time to sort of
We'll take
filter
as
them.
many as possible. Yeah,
of course, filter them because most of the questions are bundled together. And I think you have answered most of them already. Maybe I can just highlight one question because what I could see here, so perhaps I need your help in explaining the audience that what we are talking here is more for the screening of patient for upcoming risk of heart failure. Now, Dr. Sayyed's question is, can we clinically differentiate between preserved ejection fraction heart failure and reserved ejection fraction heart failure or immediate degree hypertension? I mean, that way. So I think, so your point of view, sir. I mean, can NT-proBNP be used?
The definition is, Dr. Sayyed's question is really insightful and very tough. The definition is based upon ejection fraction.
Yes.
More than 50 preserved, less than 40 restricted. But his question is, can we differentiate clinically based upon the symptoms and signs? That is what sir is asking. So Dr. Sayyed, thank you. In general, those with restricted ejection fraction will have a higher degree of breathlessness or dyspnea. They will become dyspneic upon lesser exertion. That is the basic point. Those with the preserved ejection fraction may have a relatively higher diastolic blood pressure. So these are 2 pointers. Those with restricted ejection fraction will have more of edema. In general, restricted will be more symptomatic, preserved will be less symptomatic in general. Another question from Dr. Manju is, how do I differentiate heart failure from ischemic heart disease and cardiomyopathy? So the gold standard, madam, will remain a coronary angiography, the traditional one. But if you want to be non-invasive, you can try a coronary CT scan, CT coronary, and also calcium score. But these are screening tools. They are screening tools. They will not replace the gold standard.
Yes, exactly.
NT-proBNP will be higher in heart failure. So actually NT-proBNP can be done, madam. If the heart failure is very high, that means patient is in active heart failure. If the NT-proBNP is relatively high, patient is at high risk. Another question is from Dr. Mekala, Dr. Bhushan, if you allow me. So he shared a case of a very challenging case. 15 years of diabetes, now landed with MI. Lifestyle modification is important, well-controlled diabetes, but cardiac problem was not inevitable. Or we could have postponed by 10-20 years. So we could have given prophylactic statin. We could have changed the glucose lowering therapy. Even if it was good, we could have added SGLT2 inhibitor. Had there been microalbuminuria, we could have added finrenone. So these are multiple things we could have done. We could have increased the exercise. We could have changed the exercise. Maybe patient was doing only yoga every day. We could have said, please add some resistance exercise. Maybe patient was doing lots of resistance exercise. We should have said, do aerobics. Some day you do Bhangra, other days you do Kathakali. So these are things that we could have done. But now that they have MI, now I think we should rehabilitate the patient, add aspirin, and become more vigilant. And in such a patient, NT-proBNP can be done every 6 months also. Dr. Bindanath asked about when to test. So in acute phase, of course, you will test. But like Dr. Bhushan said, in asymptomatic patients, in OPD, we should check every year. At least in some patients, you might wish to check every 6 months. Why we tell the patient? We have to tell the patient, this will tell us about hospitalization 6 months in advance. So we have 6 months to prepare you to prevent the hospitalization. We have drugs which will act upon this NT-proBNP. We can check again after 6 weeks, and we will be able to prevent that hospitalization because we will give you the right therapy. No other biomarker will have the same prognostic value, Dr. Mitesh, but you should do HbA1c, microalbuminuria, HSCRP along with that. But clearly, the value is maximum for NT-proBNP. Dr. Bhushan, perhaps you would like to share our regulatory approval. So what does our regulator say now for NT-proBNP? Do they say I should use only in the ICU or ICCU or emergency, or do they say I can do it as a preventive, as a prophylactic tool?
Correct. So thank you so much for asking this question, because this is very valid from the medical legal perspective as well. If I can highlight this issue, that clinicians do need to know that which biomarker has been approved by the regulatory authority here. So HbA1c, microalbuminuria, and all other anti-glycemic biomarkers, sorry, glycemic control biomarker, they will give you the picture, what is the kidney status, what is the glycemic control out there. But NT-proBNP is the only one biomarker which has approved by Indian regulatory authority, which can tell you the status of cardiovascular ecosystem in the patient who has been diagnosed with T2D. So this is something that all clinicians have to understand, because now, as you pointed out, sir, ADA, ESC, AHA guidelines, and we expect that even ESI, I mean the Endocrinology Society of India and RSSDI guidelines in India also take cognizance of it. Then it becomes all the more of importance that doctors should understand this is the only biomarker which tells you the possible risk of heart failure and other cardiovascular diseases. And of course, you pointed out the higher the A1C, obviously the risk would go higher. But NT-proBNP is something else, because that is backed up with more than 20 plus studies in this overall ecosystem. And thank you so very much. Because, sir, if you could allow me, I just wanted to highlight this one important point for the audience. Now, NT-proBNP is perhaps, as sir was mentioning, this is the gold standard biomarker for diagnosis of heart failure. The patients who are showing acute signs and symptoms who are suggestive of heart failure. Now, what we are talking here about the T2DM patients who are not showing any signs and symptoms. And that is where regulatory body of India has approved that in T2DM patient, this test can be done to understand the future risk of heart failure. Perhaps that is what our audience wants to know, screening versus diagnosis. So that is the reason why what Dr. Kalra was saying, that 125 cutoff, some of the cardiologists in the audience would think that perhaps this value is much lower, what we have seen in our experience. But we are not diagnosing heart failure here. We are just predicting
it after 6 months.
Exactly. So the value has to be lower, because this is not captured by the imaging modalities, the structural damage out there. So if we understand this fact, then it becomes very easy to convince the patient as well. The point of patient communication with the help of paramedic staff and the doctor himself, as you pointed out in your talk, sir. So this is what we wanted to bring about to the audience here, sir. If I move to the next question from the audience, I think
this is when we speak of precision medicine,
precision
medicine will only be as precise as precision diagnostics.
Yes.
So see the precision here, it's in picogram per ml. So that's almost like nano kind of technology. So the precision diagnostics is leading to precision medication. Dr. Kishan's question on water restriction is important, because there is an overlap between fluid overload and heart failure, especially in nephrology setups. So here again, you can use NT-proBNP for triage. If the NT-proBNP is very high, the cardiac angle will be more. If the NT-proBNP is relatively less high, the renal angle will be more. This is in the acute phase. But even in chronic phase, in asymptomatic people, someone comes in with slight edema, creatinine 1.7, should I refer to the cardiologist or the nephrologist? And in today's world, it is a very, very good idea to share the responsibility. It is a good idea to have colleagues on board. So then NT-proBNP will help.
Oh.
Yeah.
So great, sir. I think perhaps I'm just quite cognizant about the time of the scheduled webinar.
Yeah,
We are
but we'll
already
take a
at
few more
9.
comments in a minute or so. Dr. Kunal has raised a very good point that yes, NT-proBNP is a useful screening test for heart failure. You can pick up heart failure before the structural changes occur. So that is also precision diagnostics. It is more precise than the echo. And even if there is only diastolic dysfunction, NT-proBNP will be raised. And again, 125 and above, Dr. Seethamani has asked this question. We follow up more aggressively, maybe every 6 to 12 weeks. And we go into guideline-directed medical therapy. Now, sudden cardiac death, how to diagnose and prevent, really tough, Dr. Sepeli. But comprehensive care, don't forget to tell your patient to stop smoking. Ask about alternative therapies that they are taking. Rule out atrial fibrillation. In atrial fibrillation, the cutoff for NT-proBNP is a bit higher. And yes, Dr. Mohammed, we would like to do for all patients and with diabetes from year 1, type 2 diabetes from year 1, type 1 diabetes from year 5 onwards. Okay, and type 2 diabetes can be corrected by cutting down carbs, provided that we don't get the patient into ketosis. Because when the patient goes into ketosis, the short term, the speed may be very good, Dr. Mohammed. The speed of weight loss, the feeling of well-being, but the velocity means speed with direction, that will go in negative. After a few weeks, you will find that hyperuricemia will come in, dyslipidemia, electrolyte disturbances, arrhythmias, and we will finally end up in trouble if we limit the carbs too much. So carbs, at least 100 grams should be taken per day, and comprehensive therapy is required. The point of NT-proBNP is it helps us individualize, it helps us optimize this comprehensive therapy for each and every person living with type 2 diabetes or type 1 diabetes.
Great. So, sir, thank you so much for this insight. Just the last point I want to highlight here, because this is something we have been working on this particular part. I mean, answering all the questions from diabetologists. So, generally the concern comes from the clinicians that do we have the local Indian data available about the cutoff value, the authenticity of cutoff value, or the reliability of the cutoff value in Indian population. The general assumption that because we are more prone to T2DM because of so-called Indian phenotype of T2DM. But now glad to share with you that one of the most prominent endocrinologists from western part of India, Dr. Amey Joshi, one of the students of Dr. Kalra, I think he has done an extensive study in more than 1,000 patients, and he has screened each and every type 2 diabetes mellitus patient in his actual practice, and he has validated the cutoff value of 125 units. In fact, he has confirmed that more than 45% of his T2DM patients who are asymptomatic of heart failure, they have been picked up by this NT-proBNP screening, and he has modified the treatment from antiglycemic to more of a cardiovascular preventive, keeping the cardiologist on board. So that is what I wanted to highlight for the entire audience here. And with this, I think considering the time, maybe we might want to close this meeting because this is Friday evening and everything else into the place. If you are okay, maybe we can proceed with the closing of this meeting. Yeah, Akash, over to you, Michael.
Thank you so much, Bhushan. I take this opportunity firstly to thank Dr. Kalra on behalf of everybody, all the experts who have joined us this evening. Sir, it is an absolute honor to listen to you, to understand such valuable, especially novel solutions that come into the healthcare ecosystem. When experts like you speak, it really adds a lot of value about how do we drive adoption of such novel technologies. Who would have thought that a Maslow's hierarchy of need could be mapped to managing or diagnosing, T2DM patients when we speak about heart failure, or the concepts of karma that you bring inside. It's just so heartening to listen to this, understand such concepts which might otherwise require in-depth understanding. But the way you put it, sir, across, it's an absolute honor to just listen to you. Thank you so much, sir. In fact, in your words, if I would put, the point of care testing actually opens up the high fidelity, the hi-fi opportunities that you spoke about, the high patient-doctor relationship, which would actually be empowered by same visit decision-making because of the point of care device that could be used in-house, a higher patient satisfaction and adherence to the clinical journey with the doctor, higher quality validated testing results because they are now available at fingertips, and even higher opportunity for clinicians to discuss and plan the next actions with patients within the same visit. So that's the power of point of care testing. And in the era where the technological advancement is happening at exponential rate, it's devices like this that will actually bridge the gap between access solutions of diagnostics and the patients. So, sir, once again, thank you so much on behalf of entire Roche team and all our doctors who've joined this evening for such insightful talk and discussion. It's been an absolute honor. I also take this opportunity to thank all our audience members who've joined us this Friday evening for this insightful discussion and for understanding the newly launched claim on screening type 2 diabetes patients for managing heart failure. We wish you a very good rest of the evening and a happy weekend. Wishing all of you a very happy health. Thank you so much. We can officially close the webinar.
And just remember what WHO says, it's my health, my right, but it should become our health, our right. So we should all work together to ensure that the right to best possible health, to optimal health is achieved for everyone. Thank you.
Absolutely, sir.
Yeah,
So
absolutely, sir. Yeah, completely. Thank you, sir. Thanks.
Thank you.
Thank you, sir. Thank you so much, everyone.
Jai Hind, everybody.